started the timer, and here is your station. Okay, so if you have read and understood, considering clinical examination station, kindly begin.
Ma'am, first of all, I will wash my hands.
Yes.
I will enter the room. I will wash my hands and I will greet the patient. Good morning. I'm Dr. Kuldeep. I'm one of the surgical candidate. May I ask your name and date of birth, please?
I'm 56 years old, Tom. Or is it a woman?
Okay. Good morning, sir. I am here to examine your the swelling with which you came to the with which you are concerned, sir. It will involve the feel and looking at feeling of the lump, sir, and the swelling, sir. It
Yes.
shouldn't be painful. It shouldn't be painful, but it might be uncomfortable. It will be involving looking at the lump as well as feeling of the lump
Yes.
by inserting the finger in the mouth and from feeling outside the skin.
Yes.
Can I go ahead, sir?
Yes.
Okay, thank you. Do you have any pain, sir, before starting?
No.
Sir, during the examination, if you feel any discomfort or any pain, just let me know. I will stop there and after, sir.
Okay.
So you can sit comfortably. I will continue with my examinations. Ma'am, I will sit. I will stand in front of the patient and I will
Okay.
look at the patient's general condition. I
Yes.
will see whether there is patient is cachexic or not. Whether the
Yes.
patient there is where is the swelling? Is it unilateral or it is bilateral? And how is it? What is the size of the swelling? I will look from the side also. How is the swelling? Whether it is involving going behind the ear also, in front of the ear also, whether it is unilateral, whether it is bilateral, or it is involving any facial, it is associated with any facial deviation or not. And I will check for the overlying skin, whether there is any scar mark or whether there is any signing discharge or not, and whether there is any cervical lymphadenopathy or not. Then I will go to palpation. I will palpate the swelling. I will go behind the patient. I will ask the patient to bend his neck to relax the muscles and around the neck. And I will start my palpation. I will ask the patient again, if you feel any pain, just let me know. I will stop there and after. I will feel the I will feel the swelling from the behind, and I will note the site of the swelling. I will check for the size of the swelling. I will check for the borders of the swelling. I will check for the consistency of the swelling. That is firm, rubbery, nodular, or anything. I will look for the. I will check for the fluctuation. I will check for the I will check for the fluctuation, and I will check for the warmth of the swelling.
Good.
And I will check for the tenderness, and thereafter I will check for the
reducibility as well.
Mobility and reducibility, and I check for the facial nerve. I will ask the patient to raise the eyebrow to
Yes.
check for the orbicularis muscle. I will ask the patient to clinch, show me the teeth for the buccinator muscle. I will ask the patient to puff the air in the mouth. I will ask the patient to stretch the neck muscles to look for the platysma to check for all the nerves of the face, all branches of the facial nerve. And I will check for the I will check for the lymphadenopathy by standing behind the patient. I will gradually palpate the all the group of lymph nodes, cervical group of lymph nodes. I will start with submandibular node, then I will start with submental, mandibular, parotid. I will check for pre-auricular, post-auricular along the interior border of the sternocleidomastoid. I will check for the supraclavicular lymph node, posterior posterior lymph nodes around the trapezius muscle, and I will check for the occipital lymph node.
Yes.
And I then after, ma'am, I will put a gloves, and I must having wearing the gloves, and I check for the I will go for a bimanual examination. I will ask the patient if patient is having this procedure can cause some discomfort, but I will be very gentle. If patient is having pain, just let me know. I will stop there, and after I will insert my gloved finger inside the mouth, ma'am. I will check for the opening of the parotid, which is against the second upper molar, and I will feel from the outside also. I will feel for the bimanual examination of the parotid, ma'am.
Very good. With this bimanual palpation, what are you trying to feel?
Ma'am, I will see for the extension of the mass, as well as the stone, ma'am. I will try to see for the stone.
Okay, continue, please.
Ma'am, I will ma'am, I will check for the opposite side also, ma'am.
Yes.
And I will do the same examination towards the opposite side also, ma'am.
And would you go for the you've done both whole examination on the other side as well, and then
yes, ma'am.
Probably do the transillumination test.
Yes, ma'am. I will check for the transillumination test, ma'am.
Yes, and
I will check for the
if there is
yes, ma'am. I will complete, ma'am. Sorry.
Yes.
I will check for the auscultation. I will check for the bruit for any carotid AV malformation or aneurysm, ma'am.
Okay, and then,
ma'am, I will wash my hand, and I will thank the patient,
yes.
And I will conclude my case, ma'am.
Yes, good. You remember to do this, because 4 or 5 seconds just remain. Remember to thank the patient and remember to wash your hands. Okay, kindly please present your case.
Today I have examined a 56-year-old male who is a heavy smoker, presented with the swelling on the right side of the right side in front of the ear for 1 month, and which is firm in consistency, and it is non-tender and with no facial nerve involvement.
Okay, so what are your differential diagnosis?
As patient is a smoker, ma'am, my first differential will be a tumor, ma'am. I am thinking in view of tumor, ma'am, benign tumor, ma'am.
Right. What else?
It can be a infective, ma'am, parotitis. It can be parotitis. It can be malignant neoplasm. It can be inflammatory phenomena, ma'am.
All right. So can you please tell me if what investigations would you ask for?
Ma'am, I will ask for, ma'am, because I am thinking in line of a tumor. I will go for a radiology, ma'am. I will go for ultrasound of the neck. I will go for CT scan, and I will go for MRI, ma'am.
Why would you do MRI?
Ma'am, to look for the perinuclear soft tissue involvement, ma'am, around the neck.
Okay, very good. What management options can you offer to this patient?
Ma'am, if it turns out be some suspicion on the imaging, ma'am, we can go for a FNAC, fine needle aspiration of that mass, ma'am.
And
then proceed accordingly, ma'am. Whether it is a,
if time would have allowed you, how would you have completed this examination?
Ma'am, sorry, ma'am.
Yes, you would have done ENT examination, and you would have examined the other salivary glands as well.
Okay, ma'am.
If time would have allowed you.
If time would allow me, I will go for a ENT examination.
Yes, and the other salivary glands as well. Very good. Okay. Now, just a little bit. It was very good. You covered all the essential elements of the examination. But definitely we practice to improve ourselves, and to not to forget those small things that we normally do. First, once you ask the patient to be seated, for the sake of because it's winter and people normally wear high necks and clothes which are covering the neck and everything, so you'll ask the patient to unbutton first upper 2 buttons so that you could see the neck and the upper part of the neck and So this you can ask, and the patient will be seated, definitely. Right, and then once you're moving back on the back to examine the lymph nodes or for the sake of palpation. So before you do that, it's ethics that you tell the patient, okay, now I'll be examining or I'll be feeling your swelling from the back. So that patient becomes alert or knows that why are you from the front or the side all of a sudden moving towards the back, you know. So it's like better because this exam is going to be with the patient. So it's better to remember all these small things. So whenever you're moving on the back, tell the patient that you have to do what from the back so they know.
Okay, ma'am.
Right, and then yes, you did bimanual examination, you did the transillumination, you did the measurement. Okay, right. When you were telling me about the swelling, did you tell me how in centimeter the lump is?
Sure, ma'am.
You forgot. Okay, and then you can maybe tell me roughly the shape of the lump and the size, a pea size or shape, irregular or pear-shaped or circular or whatever, you know. So shape you should tell, size you should tell in centimeter. Always remember, no matter where the lump is, if it's in thyroid, if it's in parotid, or if it's in submandibular region, or it's a lipoma on the back or wherever, you always have to tell the size.
Okay, ma'am.
Yes. All right. What else have you missed? Nothing. Because you did remember to feel for the facial nerve. You did. Okay. Yes. One more. Once you are doing the bipalpation, so what are the things that you're looking for? Anyone want to tell?
Facial expression.
Sorry. Can you speak louder?
Facial expression for tenderness.
Yeah, that's for facial nerve. But for bipalpation, what are you looking for?
Yeah, a confirmation of the inspection in form of 6S.
Yes.
And also the attachment consistency in form of fluctuation test in two perpendicular line.
Yes.
Tenderness,
Yes.
hotness, the age, mobility,
yes.
relation to the action without action of the muscle.
Yes.
Also, is the swelling is compressible, reducible, or
Yes.
not? And the last one is transillumination, but the most important is the draining lymph node.
Yeah, that draining, that you have to be sure if it's opening, the duct is opening or not. So this was the thing that you missed.
Okay,
Good. Very good. Yes.
Ma'am, I just want to ask, just for example, if the examiner asks what you will do next if the time permits. So, because I don't know the name of the surgery, it's just like excision, or we need to check for in the surgery books what type of surgery to be done.
For this one,
yeah,
it's superficial parodectomy.
Okay.
Yes, this is what I asked you, but you said FNSE, and then we'll see what comes. And then even this answer is acceptable as long as you add the word after discussing with MDT.
Yes, ma'am.
And what comes, that is also acceptable. Okay. Yes, all right, you can leave. Maybe he left already. I'm reading this.
Ma'am, just one more question, ma'am.
Yes,
on the bimanual examination, bimanual palpation, we check for the tenderness, we check for the draining duct.
Yes.
And
yes.
1 point more, ma'am.
You checked for the tenderness, you checked for all the things that you have inspected on examination. So it's for the temperature, tenderness, edges, you're feeling the edges of the lump, you're feeling the consistency, you're feeling the surface of the lump, pulsatility, compressibility, reducibility, mobility, associated, if there are any associated lymph nodes, cervical lymph nodes, then you will also feel for the tenderness. So usually starts palpation and then and then temperature and then and for the duct as well. So all whatever you have seen on inspection, you will confirm it by palpation, and especially the duct. You will realize where the duct opens. Do you know where to look for?
Yes, ma'am. Opposite to the upper second molar, ma'am.
Yes. So that's where it opens. So you will ask, how would you do it? Can you please explain the procedure once you are doing bimanual examination? So you have to use the tongue depressor,
Yes, ma'am.
and then you will be able to visualize the duct opening.
Okay, ma'am.
Okay, and then you have to feel it with the finger, other finger. You know, you told me that you'll put the gloved finger in the mouth, but then you have to explain it to me by closing your eyes, as if so descriptive, as if I can imagine everything that you're telling, you know.
Yes, ma'am.
Yeah, that's how you should do it. All right, good, thank you. So started your timer, and here is your question. Right, so if you have read and understood, considering it clinical examination station, kindly begin.
Hello, I'm Nurana Abdelmomen. I'll be examining you today. May I confirm your name and age, please?
I'm Samantha, I'm 32 years old.
Hello, Samantha. So you have a swelling that's painful. Can you point to the area that's painful?
Yes.
Okay.
You. Yes.
I'll try to avoid it as much as possible. Do you need an analgesic for it?
No, that's okay.
Okay. So I'll be examining you. This will involve looking at the swelling and touching. Are you okay with that?
Yes.
Okay. Can you unbutton the first two buttons of your t-shirt, please?
Yes.
Of your
yes.
shirt.
Good.
Okay. By inspection, I'll see the size, the shape, it's submandibular, so the position of the mass.
Yes.
I'll see for redness
Yes.
or any scars or skin problems.
Yes.
I'll ask the patient to open her mouth and see the area of the Wharton duct to exclude the parotid involvement. I'll also look beneath the tongue to see if there's inflammation around the duct opening, the submandibular opening. I'll then by palpation, also by inspection, I'll check for any other swellings. And on the other side, I'm not sure whether the nerve examination is inspection or palpation, but there's lingual nerve examination, which will be the assessment of general sensation of the first of the anterior 2/3 of the tongue on the same side. And there's also the hypoglossal nerve examination. I'll tell the patient to take out her tongue and it should deviate to the affected side if there's affection.
Yes.
I'll also, there's the marginal mandibular nerve examination. I'll ask the patient to show her teeth. So if there's a problem, she won't be able to smile at that side.
Yes. Yes. Continue. Yes.
Okay, and then with palpation, I'll palpate the swelling. I'll see if it's attached to the skin or the tissues beneath it. I'll also see for hotness. If the swelling should not be able to roll it above the mandible because it's the submandibular, and I'll with bimanual palpation, I'll feel the swelling from the inside of the mouth as well. And then Auscultation, I'll auscultate for breathe or pulsations. I'll also check for lymphadenopathy with palpation, the other neck lymph nodes, the deep group and the superficial group, and everything I will do for the opposite side as well.
Yes, and
and I'll wash my hand and thank the patient.
okay, you missed the transillumination test.
Oh,
Okay.
transillumination test.
And marginal mandibular nerve examination.
The marginal mandibular to smile to show her teeth.
Yes, and then again you have to ask the patient to close the eye, and then you'll touch every time you'll touch the tongue. Patient should tell you yes after feeling. Yes. Okay, then can you, if you are done, right, can you present your case?
Okay. Today I examined the 32-year-old female patient presenting with a painful swelling on her right side in the submandibular region. The swelling has been present for 2 months. On inspection, it wasn't red. Its size was about 1 to 2 centimeters.
Good.
It was an oval shape. There was no scars. There was no scars on the skin overlying it. And from the inside of the mouth, there was no abnormalities on either side. The other side was normal. By palpation, the swelling was not hot. It was tender. From the inside, on bimanual examination, it was firm.
Yes.
In consistency.
Yes.
The skin was not attached to the swelling, but the swelling was attached to the tissues beneath it.
Yes.
So
what are your differential diagnoses?
Sialolithiasis, submandibular sialolithiasis. It's not likely that it's malignant or a neoplasm. It's not likely to be a neoplasm.
So how would you go about to investigate this?
A sialogram can be both investigatory and therapeutic.
Yes.
Because passing the contrast can pass the stone.
Yes.
Also, I could do an ultrasound.
Yes.
Ultrasound X-ray.
Yes.
And CT.
Okay.
CT.
So, what are the treatment options that you can offer to this patient?
Conservative management would be analgesics, antibiotics, and rest, and plenty of fluids to make the secretions less viscid.
Good.
Or we could do surgery. We could.
Surgery is the last option. You can offer xylogram. What would you look in that? And then xylodoscopy.
Yes.
Then is excision.
Okay.
Right. So what would you do? What would you check? Xylogram. Can it be a therapeutic alternative to be offered to the patient?
Passing the contrast can push the stone.
Yes. Yes.
And then we can open the duct.
Very good. Yes. That is endoscopic. Very good. Okay. So who would give feedback to Dr. Nuran? So that was your first ever, I think, and it's natural that you felt little bit nervous and reluctant, but that's how once you'll come every day, you'll speak out, your nervousness will go away. And the small things that you knew and you forgot because you became nervous, you'll remember them. One thing is, when I asked you to present your case, then you say, if time would have allowed you, I would have completed my examination with ENT examination and examination of other salivary glands, because submandibular is one of the salivary glands. There are many others as well. So after that, you presented. Okay. So you presented very good. When you were doing the examination, yes, you already know you forgot the transillumination test. But for the bimanual palpation also, you should tell everything that what you were feeling or what you were going for, and how you did that cotton wool test. How did you do this tongue test? And then for the marginal mandibular nerve. For the lingual and hypoglossal nerve, everything that you tested, you should tell. Right. Rest, I think it was good since it was your first time, and yeah, overlying skin and everything, that was okay. So it wasn't difficult, but then if you'll practice small things, you'll remember them.
Inshallah.
Yeah,
Thank you.
definitely. And
Thank you so
yeah,
much.
that's wonderful. Good.
Thank you.
Thank you. Okay, and here is your timer and question. Right. So if you've read and understood, considering the clinical examination station, kindly begin.
Yes, I will start by wash my hands and
Yes.
greeting the patient. Good morning, I'm Mr. Laziri, one of surgical Dr. Day. Can I confirm your name and age, please, sir?
I'm John, 55 years old.
Nice to meet you, John. Today I'm going to examine swelling in your back. It will include the look feel and doing some special test. Me listen through your swelling. Do you agree with this?
Yes.
Do you have any pain at the moment?
No.
So if you don't mind, can you take off your shirt from your waist up, please?
Good.
And
Yes.
I will examine you. I will examine you, from your back. Okay.
Okay.
So as regard the patient is having multiple swelling, I will
Yes.
start to examine the largest one.
Very good. Yes.
Yes. So as regard the swelling, now I will take a look for the swelling in form of the size, the site of the swelling, shape, the surface, and the scar over it, skin over it, any indentation, and will confirm this by the palpation of the swelling. As regards the confirmation of the 6S by detecting the size in 2 diameter, and also for consistency, I will do if the swelling is large, I will do fluctuation test in 2 perpendicular plane. After that, I will feel any tenderness by looking for the facial expression of the patient, and also comparing the temperature of the swelling by the adjacent area, even to the right side or to the left side. Otherwise, I will also palpate the edge of the patient, will define the edge or not, and the mobility in relation to the muscle. I will ask the patient, can you put your hands to your hips and tense your back muscle or shrug your shoulder? Okay. And then I will detect any compressibility or reducibility of the swelling. And also now I'm going to feel the glands in your armpit according to the site of the swelling. I will take the weight of your arm. Then I will start to examine the glands in your armpit by feeling the subscapular group, okay, and the pectoral group and the central group and the lateral group, which is the humeral, and the apical group. But the most specific one will be the subscapular, draining the area of the back, the upper part. And now I am going to considering or offer for the examiner. I will turn off the light, then it will come with cardboard rolling in a cylinder and making what's called trans illumination test.
Very good. Yes.
The content of the swelling is fluid or solid material. Okay.
Yes.
As regards this, now I will don't miss to detect any attachment by tensioning the muscle and detect the mobility in two perpendicular plane, and also to do a skin bench test to detect any skin tethering or attachment
Very
at
good. Yes.
specific point in form of a bankitum to differentiate presence of a specious cyst from lipoma.
Yes.
Okay, now I am going to listen through your swelling by stethoscope to detect any suspicious any Berwick or so in EV malformation. Now I will also to inspect any other swelling and the course. I also check any other swelling in other area of the of the body in form of the nerve distribution to exclude any neurofibromatosis or repigmentation of the skin in form of coffee oily patches. Now you can dress now. I finished my examination. I will pass my notes to my consultant to figure out your issue.
Yes. And
Okay.
you'll thank you as well.
Yes, today I examined Mr. John, 55 years old, who
Good.
presented with multiple swelling at his back of the trunk, multiple swelling in about 5 swelling. The
Yes.
largest one is about 5 by 4 centimeter.
Good.
The smallest one is about 2 by 2 centimeter with the
Yes.
same character. As regards the shape is hemispherical with normal skin over it with no attachment,
Yes.
to those underlying muscle in putting the muscle in action, with no signs of inflammation, no hotness, no redness, no tenderness, well-defined age, with mobile in two perpendicular planes. As regard no palpable pulsation, no compressibility, not reducible, and positive fluctuation. As regard the auscultation, there is no audible bruit. Regarding the draining lymph node, there is a palpable subscapular lymph node, two, with the same pattern, about 1 by 2 centimeter,
Yes.
not tender, not amalgamated, separable from each other, firm in consistency, with no signs of inflammation of skin over it.
Good. So what are your differential diagnosis?
Yes, so my top differential diagnosis is multiple lipomas, but
Yes.
I will consider the other causes of multiple swelling in form of specious cyst.
Like, for example.
Yes, specious cyst, multiple specious
Yes.
cyst,
Yes.
hematomas, vascular malformation, or neurofibromatosis, multiple lymph node, but it is not eligible here in this
Yes.
area.
Yes.
This is the and
Could be soft tissue tumor.
soft tissue tumor, yes.
Okay. How would you confirm your diagnosis?
Yes, as regards the confirmation, I will order ultrasound for
Yes.
this swelling. Okay,
Yes.
and if there is a suspicious of soft tissue extension or deep extension, I will order more advanced radiology in form of MRI. To confirm the histopathology, I will need the biopsy in form of fine needle aspiration or true cut biopsy, and
Okay.
will order
What?
routine investigation.
Yes, please. What management can you offer to this
Yes,
patient?
as regard the management will be excision for
Yes.
histopathological examination.
Very good.
Yes, for disfigurement or if occurrence of any complications.
Okay, can you please tell me how would you differentiate between the lipoma and the specious cyst?
Yes, as regard the lipoma, usually with large size, any area except the palm and sole due to absence of fat tissue,
Yes.
with slippery edge, soft inconsistency with false fluctuation test, not attached to the skin with slippery edge. But as regards the special cyst, it attached to the skin at one point, which is called punctum, obstructed
Punctum. Very good.
duct. Yes. And small
When
size.
you did the transillumination of this test, what was your result?
Yes, it trans opaque, not translucent.
Yes, very good.
Yes.
Very good.
Yes.
Okay, and there was no audible voice. Very good. Okay. 3 seconds left. Just a second.
Thank you.
Right. Good. Thank you.
Thank you.
Okay, and started your timer, and here is your question. Right. So if you have read and understood, considering the critical care scenario, kindly tell me, how would you manage this patient now? How would you manage this patient? Hello?
Hello, I'm audible, ma'am.
Yes, yes, now.
Ma'am, I will follow the CRISP protocol, ma'am. I will check with the ABCD approach, ma'am. I will check for the airway, breathing, circulation, peripheral pulses, and I will review the charts, ma'am. And I will take the history, and I will go for a systemic examination, ma'am.
Okay. What else would you do?
And I will order labs and investigation accordingly, ma'am, as per the history and examination, ma'am.
All right. And you'll manage patient is having epigastric pain, vomiting, and diarrhea. And all this.
Yes, ma'am. I will check for the. I will withdraw the blood sample. I will check. I will have a IV line, ma'am, and
Okay.
I will resuscitate the patient as patient had a history of 4 episode of diarrhea, ma'am.
Yes. So considering the scenario, what are your differential diagnoses that you'll be working on for this patient?
Ma'am, I'm as patient is having diarrhea as well as epigastric pain with raised liver function enzyme. I'm dealing with some liver pathology, ma'am.
Yes.
It can be obstructive jaundice. It can be alcoholic liver disease, ma'am. Or
Okay.
it can be hepatitis, ma'am.
Okay. How would you differentiate? Or in other words, what are the normal bilirubin levels?
Ma'am, it is 33 to 30 micromillimole per liter, ma'am.
Yes. How would you know how much is direct and how much is? Okay,
Ma'am,
you tell
I
me.
don't know exact values.
Okay, total and the direct you should, or the conjugated, or the conjugated,
ma'am.
you should
I
tell
will.
me. Okay, can you please tell me, it says urobilinogen is not detectable in urine. So what does this tells you?
Ma'am, as a urobilinogen is formed in the GI tract, ma'am.
Okay.
As patient, because of the, it can be because of the obstructive jaundice. The
Yes.
bile is not coming into the GI tract, and
Yes.
the urobilinogen is not formed. That's why it is not present in the
Very
urine,
good.
ma'am.
Can you please tell me the process of bilirubin in the GI tract?
Yes, ma'am. Ma'am, bilirubin.
Yes,
The bile
bilirubin
is secreted.
metabolism. Yes.
Yes, ma'am. The bilirubin is formed from biliverdin, ma'am. It is formed from the heme, ma'am. Heme oxidase enzyme formed in the macrophages degrade the heme product, and it converts to biliverdin. Biliverdin reductase convert into bilirubin, ma'am. Then bilirubin conjugated in the liver, ma'am.
Yes.
And it is then secreted in the bile, ma'am. And the bile, ma'am, from by the CBD, it is secreted in the second part of the duodenum. And in the terminal ileum, ma'am, it is again broken down. It got oxidized, and it converted into urobilinogen, and it will again absorbed in the terminal ileum to enter the enterohepatic circulation, ma'am.
Yes, and then how it becomes tarcobilin?
Ma'am,
Oxidization.
oxidization.
Yes. Okay. Can you please tell me what does it signify, the raised ALT, AST, ALP, and GGT? Which one of them are significant?
Ma'am, the alkaline phosphatase, ma'am,
Yes.
is significant in the because it is present in the bile calculi.
Yes.
When there is obstruction, it got increased in that alkaline phosphatase, ma'am.
All right.
The
yes. Yes, please.
GGT
continue.
is raised in, ma'am, alcoholic hepatitis,
Yes.
and SGOT and SGPT can be raised in hepatitis, simple hepatitis, ma'am.
So if you'll check the clotting factors of this patient,
Yes, ma'am.
how deranged or normal would you expect?
Ma'am, because liver helps in the kidney vitamin K absorption and carboxylation of the clotting factors of 2nd, 7, and 9 and 10, ma'am. It
Yes.
will prolong the prothrombin and APDD time, ma'am, and INR.
Yes. Okay. So can you please tell me how this clotting abnormality can be corrected?
Ma'am, we can give the patient vitamin K, ma'am. We can
Yes.
give the patient cryoprecipitates or fresh frozen plasma. We can give the patient blood products, ma'am.
Okay. What is prothrombin complex concentrate, and how it can be given?
I don't know, ma'am. Sorry, ma'am.
Okay. Can you said you suspect that the patient can have obstructive jaundice. Can you please tell me how would you classify the jaundice?
Ma'am, jaundice can be classified into pre-hepatic, hepatic, and post-hepatic.
How?
If
On the basis of what?
Ma'am, on the production of the bilirubin, ma'am. If the reason of having a jaundice is due to pre-hepatic region, like for example, hemolysis, hemolytic anemia, it is pre-hepatic. If it is due to the liver pathology, it is hepatic, ma'am. And if it is due to obstruction in the drainage of the bile, then it is post-hepatic, ma'am.
Can you give me some examples of post-hepatic obstructive?
Ma'am, post-hepatic can be happen in CBD stone, ma'am. It can happen in
Yes.
CBD stone. It can
And?
happen in periampullary carcinoma, pancreas, ma'am. It can happen in primary cholangitis, ma'am.
Okay,
It
good. Can you please tell me what are the functions of the bile salts?
Ma'am, bile salts help in emulsification of the fat, ma'am, and it provides a surface area for the absorption of the fat, ma'am.
Okay. How would you know which one is that? All right. Okay. Right. Can you please tell me how would you investigate? What investigations further would you do to confirm your diagnosis?
Ma'am, along with as lab shows some liver enzymes, and I will go for, ma'am, clotting coagulation profile which include prothrombin, APTT, as well as INR, ma'am. I will go for some imaging, ma'am, which include ultrasound whole abdomen and CT scan, ma'am, CT abdomen, and I will proceed the case and after discussing with
Okay.
MD.
Can you please tell me what are the images or what are the invasive procedures which
Ma'am, we can go
even
for
be the therapeutic alternatives
Yes, ma'am.
that you can offer to this patient?
Ma'am, we can go for
ERCP, yes,
ERCP, ma'am. ERCP, ma'am.
or MRCP,
ERCP
which
or
one?
MRCP. Ma'am, I will
Which
go
one
for
is beneficial?
ERCP, ma'am, because we can retract the stone, ma'am, through the same approach, ma'am. It can be therapeutic as well as diagnostic, ma'am.
All right. So if patient has fever, would you be worried for the patient?
Yes, ma'am. Ma'am, if patient is having fever, I can suspect for infective cholangitis, ma'am. Ascending cholangitis.
What is ascending cholangitis?
Ma'am, it is an inflammation and infection of the CBD, ma'am, common bile duct, ma'am.
What would you add in your management if you suspect ascending cholangitis?
Ma'am, I will keep the patient nil oral and I will have to start the patient on IV antibiotics, ma'am.
Antibiotics, okay. What type of antibiotics would you recommend?
Ma'am, I will cover the gram-negative bacteria, ma'am. Broad spectrum gram-negative bacteria.
Okay, good. Right, there were certain questions that you were not clear about. So when they are asking extra investigations, then these are the invasive ones they want to hear about.
Okay, ma'am.
Because the other, you've already said the basics when you were explaining about the management. So yes, read just these and then focus on these. Good. And you already know the questions that you can answer, so you can.
Ma'am, the way I fumbled for some question and I denied I don't know, is that
Is that
this
right?
have a
Yes.
is that have an impact over the or I just want to ask because sometimes we don't know everything
Yes.
even in the main examination.
And this is
this
the right way of saying it, because instead of saying I don't know, you can say, can I come back to this question later?
Okay. Okay, ma'am.
So
Yes,
learn this sentence. It's good that you have brought it up, and I'm recording as well. So others who are not present, the months they'll hear, they'll know. Instead of saying, I'm sorry, I cannot, say, can I take this at the end? Because they'll have a certain amount of questions and the time is limited. Once you have told or answered all the questions and time is still left, they'll come back, they'll put a mark on these questions that you are passing or omitting at that time. They'll come back and they'll say, okay, can you recall and answer now? So by that
Okay.
time, this is quite possible that exam has ended and you are quite relaxed. And once you are relaxed, you'll recall the answer and then you'll answer them. It has happened with many members. They, at the end, they were asked again and they could answer. They couldn't answer first, but they could answer at the end once they were asked again. So don't say pass, say, can I come back to this question later or at the end or towards the end. So just make a routine and just learn that sentence without hesitating, without wasting your time. Just say, can I come back to this question later? And then they'll reserve the question. Good. Dr. Mohammed, you said yes. Well, started the timer and here is your question. Okay, so if you have read and understood, considering it history taking station, kindly begin.
Yes, I'm ready. Hello, I am Mr. Azir, one of surgical Dr. Zair. Can I confirm your name and age, please, sir?
Okay. My name is Francis. I'm 64 years old.
Good.
Nice to meet you, Francis. How can I help you today, please?
Okay, I have been experiencing these tummy pains for about 2 days now, and also
Good.
having difficulty going to toilets. I cannot defecate easily.
Yes, I'm
So
really
that
sorry
has been
for that, but if you don't mind, I will ask you.
okay.
Yeah, I will ask you some question regarding your issue. Besides taking notes, why I'm talking to you. Do you agree with this, Francis?
No problem. You can go ahead.
Good.
It's
I
gonna
agree.
be confidential. Don't worry. So as
Okay.
regard your fresh bleeding per rectum, what is the color?
Okay, it's just fresh blood, normal blood, red blood.
Yeah, Yes. Have you noticed any blood clots?
There have been blood clots before, but not always. Sometimes it's just fresh liquid blood. Then sometimes it comes with blood clots.
Yes, only with passing stool or without?
Both with and without passing stool.
Okay.
With and without, yes. So is there any suspicion for that it is coming from anywhere else? Anywhere else?
No, apart from passing the blood when I'm going to toilet, there's no other passage of blood from any other place.
Yes. So can you told me that about amount, a teaspoon or more than this?
It's more than a teaspoon. Like if you're using a cup, like half of a cup.
Half a cup, yes. I'm really for that. But have you noticed as regard your tummy pain, can you point of the site of the pain, please? Where is exactly?
Okay, I experience it most on the left side, the down parts of my tummy on the left side.
Left side. Okay. So can you tell me that rate
Down
out
parts of
this
my
pain
tummy
out
on
of
the
10?
left side. I didn't get
Can you
that.
rate out
Can you
this
repeat that?
pain?
How does what?
Yes. Rate out this pain.
Okay, the pain is about 5 out of 10 when it comes.
Yeah. So is it radiating to anywhere else?
Just the down parts of my tummy could move down to the right side sometimes,
Right
but
side.
not always.
Any aggravating or relieving factor?
Especially when I eat, sometimes I experience it. Sometimes could come on its own. Then when I go to toilets and pass things out, it relieves a bit.
Yeah. So have you not do you, any weight changes? Any weight loss?
Yes, in the past few months, yes, there have been some weight loss.
Yes. Is it intentional?
No, this is not intentional.
So what's about your appetite?
It's not very good. It's not very good.
So have you noticed any fever?
Just not always there, just once in a while, but not very serious.
So do you receive any blood thinner?
No, I'm not taking
So
any blood thinner.
any bleeding from other body orifices?
No, just when I go to
Any
toilet.
mucus from your anus, bottom passage? I'm sorry. Any mucus?
No mucus.
Have you experienced any skin changes or dry eye?
No,
Any trauma to your bottom passage?
no, I have not had any trauma before.
Yes.
It just comes
Any
like
swelling?
that when I'm ready.
Any swelling or pain from your bottom passage?
No swear. I've not noticed any swelling. For pain, not always there, except when I'm having the difficulty going to toilets and I have to force. That's when I feel some pain, but apart from that, no pain.
Yes. So any family members has had like sinister in any sinister in his tummy?
No, none that I know of.
So do you smoke?
I used to smoke before, but I stopped.
Yeah. Do you drink?
Yes, I do.
Yes. How many units per week, please?
I take the regular beer. I can take when I close from with my friends. I can take about 2 bottles a day.
What's your job, please?
I'm a construction worker.
Yeah. So with whom you are living at home?
I'm living with my wife. My children are not with me.
Okay. So do you have any other issue regarding medical condition?
Okay, can you present your case now?
Yes. Thank you for your time. I will pass my notes to my consultant to figure out your issue. Thank you, Francis. I took a history from Francis.
Yes.
Who, yes, who present 64 years old. He presented with a history of fresh bleeding per rectum that started about 2 days ago with a history of change of bowel habits, with long history of constipation. He also in the amount of about half an a cup with
Yes.
no bleeding from other body orifices, and he didn't receive any blood thinner. As regard, he also has a tummy pain in the left side, referred to the right side, a little bit decrease with passing stool. He don't have any mucus phlegm or
Yes.
fever or any other complaint or any symptoms suggestive of upper GI bleeding. So my top differential diagnosis is in form of the weight loss.
Yes.
Is colorectal cancer, but I will consider other causes of bleeding per rectum in form of inflammatory bowel disease, rectal
Yes.
ulcer, rectal polyp, infective gastroenteritis, inflammatory bowel disease, and also upper GI source of bleeding or bleeding
All right.
tendency.
So what are the
Yes.
most important investigations that you'll carry out?
Yes, the most important to rule out colorectal carcinoma is colonoscopy with or without biopsy according to the gross lesion. And it is, if it is available in OBD, I will do sigmoidoscopy,
Good.
rigid sigmoidoscopy. Yes, but other investigation I will need to arrange in form of full blood count, tumor markers,
Yes.
bleeding profile, calprotectin, stool culture and the analysis, and
Yes.
also ECG, mesenteric angiography, CT
Okay.
with contrast.
Yes.
Yes.
Good. Thank you. Time has gone. Right. When I interrupted you and asked you to present your case, then because it's history taking, so once you're presenting, you told me that you took history from Francis today. So you could have said that if time would have allowed you, I would have completed my history with
Yes.
patients. You did ask family history, you were asking social history. So drug history or the past history, because past medical or surgical history was not asked. And then the systemic history was also not asked. And then ICE was also not covered. So once you're starting to present the case, so then you by default say that if time would have allowed you, I would have completed my history with this. Then yes, everything you asked, very good. One small thing that you remembered yourself as well, that to ask the bottom part. But then when you were asking about the aggravating and relieving factors, then patient does not understand what is aggravation and what is relieving. So you have to use the layman terminology, that is there anything that you do which makes which increases the bleeding or which makes it worse, or is there any rest or anything that you do which makes it less? So instead of aggravating and relieving these words, you have to use the layman terminology.
Yes.
Right. Just these small things.
Yes, the issue usually in the time in history taking,
Yes.
as there are many
That's why.
questions. I wanted to cover all item in
Yes.
as example for the complaint itself. I need to cover, and for past history to comply and associated
For the
symptom.
complaint, I think you did cover a lot. Yes, but the small, because history is long, and here your enemy is the time, and we have to practice.
Yes.
Practice. That's why I asked you, kindly prepare history taking station every day, one, so that you can practice.
Yes.